Welcome to the Nursing Post podcast, all nursing, all the time, with Ashley Moore and Rosa Horsley. In this podcast episode, we discuss workplace violence and healthcare workers' safety on and off the clock. Our goal is always to help and inform and start conversation.
As nurses, we can probably think of an incident in which a patient was inappropriate or aggressive, whether it was verbally or physically. If not, then we've probably witnessed it or we've heard other nurses talking about it. That's kind of been my experience.
Mm-hmm.
I know that I have been absolutely verbally assaulted and can probably teeter-totter on the physically, personally. In healthcare, workplace violence is an ongoing issue. It's something that we know, and even in the news, we're seeing where healthcare workers are being assaulted in public just because they have on scrubs.
Absolutely.
And this is just, in my opinion, unacceptable.
Well, that's why we're doing this podcast.
Of course, because of who we are and the way we think, we always like statistics. And so we do have some statistics that are from the Joint Commission, and it's on physical and verbal violence against healthcare workers, and it was published in 2018.
About 75% of the nearly 25,000 workplace assaults reported annually occur in healthcare and social service settings. Workers in a healthcare setting are 4 times more likely to be victimized than workers in a private industry. Workers in a healthcare setting have a 20% higher risk of experiencing workplace violence. The alert states that most incidents of workplace violence in healthcare are verbal. However, other acts of violence include assault, battery, domestic violence, stalking, and sexual harassment. While the workplace violence occurs in all care settings, the most recorded incidents are in the emergency room and inpatient psych settings. Studies have also shown that violence in healthcare workplaces is underreported, which is the problem in and of itself.
Yes.
So there may be considerably larger episodes of workplace violence than the current statistics suggest. The American College of Emergency Physicians reported that 70% of emergency room physicians have reported acts of violence against them, yet 3% press charges.
That's a big discrepancy.
That's a huge discrepancy.
That's, I think, what makes people feel that this is okay, that they can act in any way that they want to, and there are no consequences for it because it's against healthcare providers, and we're supposed to just deal with any and everything.
I agree with that. And I also feel it's because we, as healthcare professionals, try to be compassionate.
Yeah.
And I think we cut people a lot of slack for their bad behavior.
For sure. Absolutely. We try to be understanding, especially if we're giving bad news or something like that.
Mm-hmm.
We try to say, well, how would we feel if we were in that position? Try to be sympathetic.
Yeah, try to empathize.
But it still doesn't give people a right to be nasty. It really doesn't. I mean, if you're in your right mind, you have the ability to say, well, hold on. This is not this person's fault. Or if a nurse or another healthcare worker, any sort, says, I understand that you're upset right now, but you have to talk to us appropriately, you have to behave appropriately, then that should be your newsflash.
I agree. So what does workplace violence include?
So you have verbal and physical threats. That's kind of a given. We encounter gang violence, and this is typically in like an emergency room is where you're going to see most gang violence kind of related issues or urgent care. We have distraught family members who may be abusive or, that it could even come into like an active shooter situation or something of the sorts where they're coming in looking for the person. And that kind of leads into the domestic violence that can spill over into the workplace. And this is not just with the patients. It can be with your coworkers who are in a domestic,
your employees, your staff.
Yeah. So anybody can
absolutely
be in a situation where they're dealing with domestic violence at home. And then at that point,
it just spills over to the workplace.
Right. And then lastly, which is the one that irritates me the most, but, workplace bullying, which is a huge problem in nursing. I think we've done something on this before.
Yeah, on our previous episodes.
And this is something that we can stop immediately.
Absolutely. It starts with you. Just be nice.
Yeah. And then that'll be one less thing to add to our workplace violence list.
The New England Journal of Medicine says there are 4 types of violence that can occur in the workplace. The first type is by the perpetrator who have no associations with the workplace or the employees. Just it's random.
Right.
The second type is the assailant who is a customer or a patient of the workplace or related to the employee. So usually it's committed by the patient, their families, their friends, or it's just prevalent against healthcare workers. And then the third type is when the attacker is a current or former employee of the workplace. And I remember in the news 20 years ago of a disgruntled, terminated postal worker who went into the post office and became an active shooter. And they literally have termed that as going postal.
Right.
And the fourth type occurs when the perpetrator has a personal relationship with the employee, but not with the workplace. So your coworker's significant other does not have a proper home life. They're being abused, mistreated, what have you. And then that significant other has now come onto or into the workplace where your coworker is.
Right. And this is a real situation. This happens, especially if a person is trying to get into a better situation and they're leaving that person, and that person just loses it.
Yeah.
So there are a couple of risk factors and causes for workplace violence. Working directly with people who have a history of violence, people who abuse alcohol or drugs, gang members, distressed relatives or families of patients or clients. You can see where that can really get into a situation pretty quickly. We do, as nurses, work in stressful situations and conditions where patients are being given bad news. People are being told that they have terminal conditions.
Yeah, they have 6 months to live, or your wife is passing, or
just, maybe a child getting a diagnosis like type 1 diabetes. No, it's not going to kill them, but it's still a lot, and it's a huge
stress.
Yes, it's a huge stress on the family, and that just may be enough to take that family that was already living on edge over. And you don't know that. There's a big lack of organizational policies and or training for security or for staff to figure out how to de-escalate situations, whether it's from patients, clients, visitors, staff. How do they react when people are being verbally abusive, to not make that turn into something that's physical? And I don't think that there's enough training on this. I know that I haven't hardly had any training on this. It's the same talking to convoys.
Try to redirect.
Exactly.
That's the biggest one I think I've ever heard over and over again. Try to redirect.
Right.
Try to redirect.
Right.
It's easier said than done sometimes.
Absolutely.
Especially in a dementia unit when your patient's already at a 10. And you're trying to bring them down to a 1.
Right. At that point, you're settling for a 7.
I'd be happy with 8.5. It's difficult.
It is. And you're not always arguing with somebody that's in their right mind. And to say arguing, that's not the right term. You're not always trying to have a
rational conversation with somebody who's irrational.
Right. And so that you really have to think about what you're saying, and you really have to pull on your inner self to be like, okay, this is not directed at me. Even if they're saying things that seem like it's directed at me, they don't know me. And it's hard to take yourself out of that situation because most people want to automatically get defensive.
Yeah, I would say that fight, flight situation thing.
Right. And so when you have all of those things that you take into consideration, and if you're leaving, especially like big hospitals where there's poorly lit corridors or rooms and parking lots, I mean, if you've had a stressful situation and they're sitting there waiting for you, well, then that's a whole other situation.
Whole other ball game.
So I know with mental health, I've never really been in a place where it was strictly mental health, except for when I was doing my clinicals. Mm-hmm. There really wasn't any kind of security on premises.
Wow.
And this was in a locked unit, a locked facility. It's a hospital it's like a half hospital, half, ward for patients who have committed very heinous crimes, but they are mentally disabled. Mm-hmm. And then there was a actual facility that was much like a jail that was on the premises, but it was pretty good ways away from the hospital. They had security and police, but the hospital itself, I don't ever remember walking in and there being anybody other than who was immediately at the door. Because you had to go through metal detectors and things like that, because everything had to be very structured. But when you went onto the unit, there wasn't any like actual guards or police officers that were there to help. It was all just nurses and staff. And, I remember going there and it was like, oh, just make sure you don't turn your back to anybody.
I was like, that's a good piece of advice, though.
I'm like, pardon?
That's a good piece of advice.
So like, don't turn your back. Yeah. Like, don't have your back to anybody. And I'm like, but like reformed, and they're not in a state where they're secure in any way. So like, there's like common areas that they were gathered, and I'm like, you had to really think about how you maneuver to not have your back to somebody. And they said, don't get backed into a corner. So I'm like, don't turn my back on anybody and don't get backed into a corner and watch for all the people that are walking around me. Yes. Like, yeah, that doesn't sound intimidating at all to a new student.
No, it sounds like purposely having to be paranoid.
Yes.
In my mind, that's what now I am paranoid.
Well, yeah, it did kind of embark that
oh my
fear.
Gosh. Yeah, like now I have to watch my back.
Yes, absolutely. And so that's an issue. I mean, there should be people, in my opinion,
you should feel safe to go to work
on every unit. That,
absolutely.
If I have to have keys and cards and codes to get from one place to the next, and every door is locked, then that should, like, I don't know, be a red flag that we need more than just nurses.
I agree with that. So understaffing, especially during meal times and visiting hours, understaffing has been one of the biggest issues in nursing ever since I was a nurse, since the beginning of time, right? It's still an issue, even more so today. When you are not adequately staffed, you leave your employees open, like really sitting ducks.
Absolutely. Well, yeah, because the patients don't care that you're understaffed. The family members don't care that you're understaffed.
At all.
I mean, unless they work in the medical field.
They may sympathize,
but then they
still don't care.
No, they want their family or patient or themselves taken care of.
There's always a high turnover in nursing, which causes some stress, to the employees and as well to your patients. If you're working in a long-term care unit or a SNF care unit and there's a high turnover, your patients are just as stressed as your employees are.
Yes.
Because they can't find consistency.
Right.
Staff working on isolation or in situations in which they can be trapped without an escape route, working alone in a facility, like you mentioned, or in a patient's home. We do have a lot of home health care nurses that, that's their living. And then they have lack of means of emergency communication. What happens? What happens when they're alone and they're being assaulted?
Right. And they're in an unfamiliar environment. So they don't they're already in a situation where they're not at their top.
Working in ALF, we had one building that was for assisted living, normal community.
Sure.
And then we had the dementia lockdown unit.
Mm-hmm.
Okay. And one of the rules and regulations was, of course, the doors had to be locked.
Sure.
You know, it's
Makes
a lot.
sense.
You can go in, but you had to have a code
To get out.
Because you don't want your patients wandering, you know, because that's why they're there, right?
Makes complete sense.
So apparently they had to change the state guidelines that if you're working on a dementia unit, it's a lockdown unit, you always have to have a minimum of 2 people on site at all times because of the aggression and violence that can happen.
Right. Well, and that makes sense. I mean, they really took it down to the minimum too.
Absolutely. Let me tell you.
I mean, really, just say you need another person. At the very least, I need another person. But if I'm being assaulted and you're there to help me, who's there to help all the rest of the patients?
Exactly. Food for thought.
Nobody.
Food for thought. Of course, like we said earlier, there's an underreporting of attacks. And I think this is everywhere. Literally everywhere.
Mm-hmm.
Been in some, you know, verbally aggressive situations with dementia patients before where they're cursing me up and down, you know, the wall or whatever and full of crap, whatever. I've had some, you know, step into my face. I didn't report it. Like, of course, I'd make a note.
You document
it.
Right.
I just didn't see the benefit of having to press a charge or...
Right.
Because you have that option, whether the patient's demented or not. I mean, you might not have a leg to stand on in court, but you do have the option of pressing charges against these patients.
Right.
That are, you know, aggressive or assault you.
Right. Well, and I think that this is where nurses get into the situation because we're like, well, yeah, we'll document it. Well, you know, but we don't really let it go further than that because, well, they're demented. And
how much of it is their fault?
They're not in their right mind. And then we have a lot more grace. I know I have a lot more grace for people who have dementia of any kind than people who are just mean. Like there's a big difference in my, I mean, if you come at me and you're nasty because you're nasty, well, then we're going to have a problem.
Yeah, that's going to be a charge.
However, if you have dementia, I mean, even if you like grab me or whatever, I'm going to be like, they don't know what they're doing. It's like getting mad at an infant for pulling your hair.
Absolutely.
They don't know what they're doing. So we tend to go, well, they don't know. We document it. But I think it's really important that we do make sure that the people in administration are aware. Yes. Because if we have one patient that, even though they're demented, are getting to a point where they can see a trend of escalation, then maybe we need to rethink either their medications or are they still safe in the facility? Because there are other patients. And if they're going to do that to you, who's to say they won't do it to that person?
Patient. And that's happened. That's happened in assisted living. And we've talked about this in our podcast about dementia.
Yes.
Where when you get aggressive and physical, you know, placement in assisted living becomes extremely difficult.
Right.
And a lot of times you end up having to go to a long-term care unit or, you know, a state facility.
Right. And maybe we could care for these patients better and get to these patients before they escalated if we had better staffing ratios.
I am in 1,000% agreement with you.
So
1,000.
Just to add my little 2 cents in with that.
1,000. Remember those two staff members on that lockdown unit on third shift.
Right. You can't do but so much. There's just no way. And they don't sleep at night. Just saying.
Yeah.
I work third. Gosh. They don't sleep. For everybody who's never worked third and they think they sleep, they don't sleep.
No, they are night owls. I'm just saying. There is a perception that violence is tolerated and victims will not be able to report the incident to police and or press charges. rest assured, if you are a patient and you have decided to be mean, nasty, or postal to your healthcare worker / provider, you may have charges pressed against you.
Absolutely.
Just be aware. It's not okay to be not nice.
Correct.
And in saying that, I think the next topic that we're going to talk about, more so now than ever, is extremely important.
This is so interesting because I know somebody who was directly affected by this. And you don't really think of it, but I think a lot of people are going to look down when we kind of get a little bit more into this. They're
going to be like, oh my God.
I didn't even notice this. Yeah, because I was kind of in that way until here recently. Mm-hmm. Absolutely. House Bill 39 states the photo identification tag shall include a recent photograph of the employee's first name, the employee's title, and the name of the healthcare facility or employment agency, period. That's the end of that statement. So the big thing that I want people to realize there is it did not say anything about the employee's full name or last name.
Absolutely. And I'm in total agreement. Let me tell you, Pennsylvania, hats off to you, because this bill was originated in Pennsylvania. And hats off to you, kudos to you for realizing and recognizing that a lot of us have patients that are not mentally stable. That stalking exists.
Oh, absolutely.
Cyber stalking exists. Harassment exists. And so kudos to you, Pennsylvania.
And what people don't understand is if somebody knows what you look like and they know your first and last name,
all you have to do is Google it.
I mean, you can really get far.
You can Google it. This is the age of social media.
Mm-hmm.
Now people are able to even pull up your name with your address, go in there, Google your address, and physically see what your home looks like. This is why this bill is so important.
Right. And it needs to be something that we do in healthcare around the world.
Absolutely.
I'm not just talking about the United States of America. I'm talking about
all around the world.
The world. Because this is not a problem that's local to one country.
Let alone one state.
So
it should be a mandate for all healthcare workers everywhere.
And so a notation, a marker or indicator included on an ID badge that differentiates employees with the same first name is acceptable. So you could do either a first initial of the last name or something like that. There's all different ways that you can work around that.
Mm-hmm. Absolutely.
But I mean, it has your picture on the badge, so I don't even understand why that's even truly necessary.
Yeah, if it has your picture, your affiliation, and your name,
right,
with or without an initial, because there might be more than one Ann, so maybe Ann R and Ann B or whatever.
Right.
It's more than suffice. Why does any patient have to have my last name?
Right. And I've had patients ask me my last name. Like where are you from? Like, and I think most people are just being friendly.
Yes.
We're from a small town, so I could see that. But there are some people that have been asked, and I'm like, oh, I can't give you that information. And I do have my last name on my badge.
Well, I'm going to tell them what I did to my name badge. She's laughing because it is funny.
It did take me a while to realize it.
It took a lot of people a while to realize it.
I guess I know who you are. I don't need to look at your badge.
You don't need to. Yeah, you don't need my badge as a reminder of my name. So at our current place of employment, our name badges have our photo, our affiliation.
Yep.
And then it has literally our first and last name. I am of Latino descent. So, I mean, I have quite a few names. It is what it is. I literally took correction tape, for lack of a better word,
It's like label maker tape.
Label maker tape. And I literally put it over my last name until the point where you couldn't even see the last name at all.
No, and you can't. You almost don't even recognize that that's even there because it blends in really well.
Yes.
So kudos, job well done.
So my employer comes up to me. She's noticing there's something different, right? She can't quite place what's different, but there's something different about my badge. I have a pin on it. She starts the conversation as, "That's a very interesting pin." I'm like, "Oh, thanks. That's, it's for ASD, whatever." And she's like, "What happened to your name badge?" And I'm like, "What do you mean?" And she's like, "Where is your name?" It's like, "It has my first name on there." I was like, "It's good enough. I'm the only Rosa here."
Very true.
The only Rosa here. Probably the only Rosa there ever, right?
I've been there a while. I can't think of another one.
I think, she's like, "Well, why did you do that?" And I'm like, because of social media and the World Wide Web. They don't need to know my last name. I'm the only Rosa here.
Right.
I honestly thought that she was going to ask me to take it off, but she didn't.
Well, I think it may hit a little close to home because we have had somebody that we work with that was stalked on social media because of that issue.
Makes you question why it hasn't been addressed.
Personally, I haven't, or if they have, they're probably highly disappointed, which is whatever. But that's just not, I don't know. I have this, RBF. So
I do too.
It tends to be my saving grace. So there are exemptions for not actually wearing an ID, which I didn't know this. So if the last name of the employee may be omitted or concealed when delivering direct care to a customer or patient who is exhibiting symptoms of being irrational or violent. So if you're in a situation, you can actually either, like mine has my last name on it, I could take my badge off and say I didn't feel comfortable. And then also for EMS personnel or either doctors, residents, interns, nurses, and all other, like medical professionals who work any kind of an emergency service situation, they all can put themselves, because they are the ones, honestly, that really, mental health in the emergency room, sometimes I wonder if they're not the same.
Mm-hmm. I mean, you're trying to triage, you're trying to fix a situation.
Right. And so we want to protect ourselves, and that comes first.
Yeah. A lot of our, the psych patients sometimes come through the ED and they're not stable, and you're just trying to get them through that situation.
Right.
To the care they need.
Right.
So the emergency room is often the launching pad for that. And
I think to finish up, instead of just talking about all the problems, what can we do to prevent violence in the workplace? And there are a couple of things, specifically from OSHA, that you can do, 5 core elements that we can do as individuals and entities to make this better.
I think it starts definitely with number 1, the management commitment and employee participation. So we have to be able to provide adequate resources and support. We have to have leaders that actually have authority and knowledge on how to facilitate change and how to set good examples. If it's not starting with the top of your employer's hierarchy, it's never going to trickle down.
Well, and that's so true. I mean, you have to know that leadership is in a good spot and they're there to have your back.
Absolutely. Trust, is everything in every relationship in life.
Yes. So number 2 is work site analysis and hazard identification. Being able to do an initial assessment and actually see if there are anything that is hazardous going on. So you need to be able to identify it. and having regular reassessments and formal reevaluations of incidents and things that can be done, and having that be reviewed and gone over. You have to know, hey guys, if this situation happens, this is how we're going to handle it. Mm-hmm. This is what you need to look for. And you don't need to say that once a year.
No, I think your staff should always know when there's updates in your policy, updates mm-hmm. in the world, especially Absolutely. Right now.
Oh,
because things are changing every single day.
Right.
Staff needs to be aware.
So that kind of leads into the next one that OSHA has, which is hazard prevention and control, which processes, procedures, and programs are implemented to eliminate or control workplace hazards and achieve workplace violence prevention goals and objectives. So we're actually going to make a plan, implement it, and use it.
Yep, and track it.
And so then that way you can see what works and what doesn't work.
Number 4 in this is the safety and health training, and all employees have education or training on hazard recognition and control, and it be their responsibilities under the program, even to include what to do in an emergency.
Right.
So when we all sit down and we're employed as nurses, we have to go through modulars, we have to, bloodborne pathogens, OSHA, safety. Like, this should be one of those modulars that are included.
Yeah, absolutely.
So a lot of places kind of need to step it up because times they haven't changed.
Well, yeah, it's not they are changing. They
have they're
changed.
Continuing to change
right.
every day. So keeping record and, going back to evaluate its success. So maintaining accurate records of injuries, illnesses, incidents, assaults, hazards, corrective actions, patient histories, and training can help employers determine the severity of a problem, identify trends or patterns, evaluate methods of hazard control, and identify future training needs. This helps to develop solutions and make a program effective.
Right. And so all of these things go back to you have to start with leadership, implement protocols is kind of where my mm-hmm. mind goes, and everybody needs to be comfortable with their part of the protocol.
Yes.
And then you need to track it to make sure it works.
Sounds like everything nursing related.
I mean, so that was a lot. And I'm like, okay, so
pretty much
develop,
we do every
implement,
day. Yes.
Work it out, make sure it works. If not, okay, we're going to redo it.
We need to change something. What a concept. Continuing training helps healthcare workers learn to recognize potential hazards and learn how to protect themselves, their co-workers, and their patients. So continued education, it also reinforces that violence is not acceptable and it should not be a part of healthcare.
Absolutely. You're correct. I mean, there's period. And what our goal is as nurses is we want to provide compassion, empathy, and excellent care. We want to educate each patient. That's what we want to do. That's what we go in striving to do every day. Mm-hmm. And it's crazy that the idea of any kind of abuse, and I don't mean if it's verbal or physical or anything in between, is the fact that we are finding it acceptable is appalling. We really need to focus on, especially in this instance, patients who are in their right mind, who are acting in a way that the behavior is not acceptable, that needs to be fixed.
Yeah, they need to be held accountable for their actions.
And the healthcare industry needs to take more action and hold those patients accountable, mm-hmm. or their loved ones, whoever is
perpetrating the behavior.
Correct. And so I know because as we had said earlier, I haven't had a ton of training with this situation. We were able to find a course. It's from the CDC on workplace violence, mm-hmm. and it actually offers free continuing education credits. So we'll link that in the description and back on our website.
Absolutely. That's free CEUs for those nurses out there.
Yes.
My favorite word, free. So as always, we will link our references to our website, www.thenursingpostpodcast.com. We would love for you to join the conversation and leave comments and suggestions. Be sure to subscribe to our podcast so that you can listen to us on your favorite platform, and you can always follow us on Facebook and Instagram. Thanks again for listening to The Nursing Post.